trainer,'s responsibility, the athlete, should be to determine A, if they've had a concussion, B, if they possibly have had a concussion and you're just not sure, or C, if you're absolutely sure they haven't had a concussion. And if you're absolutely sure they haven't had a concussion, then you can return them safely to the contest, in my opinion. But that requires a very thorough neurologic exam, an exam that can't be done in less than 10 minutes, and you can't make that determination that they're okay in just a minute or two. You can make the determination that they're not okay in seconds. If you see posturing, which is a sign of unconsciousness, but if you're not certain whether they've had it or not, then you have to go through a full protocol. The different areas of the brain that we test include cognition, and there we use things like orientation. Do you remember the players' colors of the opposing team? Do you remember the score of the game, what half it is, what the score was last week, things like that. We also give individuals a series of digits, usually 6 or more, and ask them to do them forward. And then if they can do them forward, which they should be able to do them backwards. And most people can do that if they're not impaired. And we give people word lists, usually 5 words, sometimes people use more. And acutely, almost everybody can give you those 5 words back. But then 5 minutes later, if you ask somebody for those 5 words, that's a more sensitive test of memory and recall. So one of the very important areas that we use, one of the legs of the stool, is the cognitive assessment. Secondly, we look at balance, because balance is very often impaired. Can an individual walk heel-toe, eyes open, in a straight line forward, heel-toe in a straight line backwards? Can they do it with their eyes closed forward? Can they do it with their eyes closed backwards? Can they stand with their feet side by side, hands on their hips, eyes open for 20 seconds, eyes closed for 20 seconds? When you close your eyes, you lose your spatial orientation. You have to use the proprioception in your feet to tell you where your body is. And it's a more sensitive way of checking for the balance assessment that your brain is giving you an awareness of. In addition to balance, tested that way, we also test it by putting one foot heel-toe in front of the other. Now the platform is more narrow. It's a more difficult test than with 2 feet side by side, a wider platform. And now we do it 20 seconds, eyes open, 20 seconds, eyes closed. With a concussed patient, almost all of them are going to have difficulty with their eyes closed and have 1 or more errors in that 20-second period of time, having to break their feet to gain their balance. And then the most sensitive of all is standing on just 1 foot. Now the platform is still as narrow, but it's not as long, so it's harder. 20 seconds, eyes open, most people can do that. 20 seconds, eyes closed, an impaired individual couldn't do that. In addition to the balance testing, we do eye tracking. We ask individuals to do 2 types of eye movements. One are called saccadic eye movements, which are fast ones, and then on the other is the smooth pursuit, which are slow eye movements. We test saccadic eye movements by having the athlete put their head straight forward. We put our fingers out to the side in front of them, and we ask them to take their eyes and glance them off the index fingers at a rapid rate. And we ask the athlete, does that make you lightheaded? Does that make you nauseous? Does that give you a headache? And if you are recovering from a concussion or have had a concussion, very often those are the symptoms you're going to have. We call that one, when the fingers are horizontal like that, horizontal saccades. When the fingers are up and down, and we ask you to bounce your eyes up and down off the fingers rapidly, that's vertical saccade. And when we have your finger out in front of the athlete, we ask the athlete's eyes to look at the finger, but to move their head side to side rapidly. That's what's called visual ocular reflex. With impairment with concussion, normally horizontal saccade produces more symptoms than vertical, produces more symptoms than vestibular ocular reflex, but all three need to be checked. In addition to that, we do what's called smooth pursuit. Those are slow eye movements, and we have the individual follow a pin or other very small object, much smaller than my fingertip, in an H distribution, up and down, cross, down and up, to see whether they see double at any time. In addition, we have them follow that pin in, and they should be able to get within 5 centimeters of their nose before they see double. With impairment with concussion, it's very common to see double, even a foot out for a small object. While the eyes are moving, we want to be looking to be sure they track perfectly smoothly, and we don't see any jerking or what's called nystagmus, something that is not infrequently seen acutely after concussion.